which we assess for the entire country after conducting the national blindness survey. I have to change myself. Yeah. In fact, we know that there's a high burden of visual impairment, and cataract is among the leading cause of blindness and visual impairment. In fact, 63% of blindness is in South Asia is because of cataract. And as per the National Blindness Survey, which was conducted between 2015 to 19, we found that 66.2% of blindness attributed to cataract alone. And now we think of universal eye health coverage. That's our aim actually by the 2030. We are targeting universal coverage, and WHO has given certain eye care indicate some specific target, and probably the most important of these targets we are discussing is the effective refractive coverage and effective cataract surgical coverage. In fact, we did this survey in 2015 to 2019, and as Dr. Sumit has cleared, at that time, the concept of effective cataract surgical coverage was not there. So we just did the survey, and an entire study was conducted, report was published, and then we got these indicators. Then Government of India asked us whether it is feasible to actually assess the effective cataract surgical coverage for the country. I'm very happy to share. When we were starting this survey, at that time we were told that India, the the definition of visual impairment is less than 6 by 18. And they suggested why to take 6 by 12 as cutoff. And I mentioned at that time we should go exactly as per the RAP 6 strategy, should not change the strategy, and 6 by 12 should also be taken. And I'm happy that that decision was taken and we could actually assess this effective cataract surgical coverage based on 6 by 12 cutoff. When survey was conducted, we were very happy. In India, we have the cataract surgical coverage. The effective was not there. It was like say 93.2% for 3 by 60 cutoff, 89% for 6 by 60 cutoff, and 74% for 6 by 18 cutoff. As you can see, at that time, while submitting the report to Government of India, we did not even calculate cataract surgical coverage for 6 by 12 cutoff. So here the study objective was, of course, to estimate the effective cataract surgical coverage. The data on cataract surgical coverage is already there. Assess the various factors, the gender and the regional disparities in effective cataract surgical coverage, and in fact, to identify other factors which are influencing the target indicators, and to actually give Government of India the baseline data of effective cataract surgical coverage in the country. Of course, we have so many indicators for cataract, but probably the most important indicator is now the effective cataract surgical coverage. And these are the calculations. I think most of people are aware of these. So what we did is we used the RAP survey data, which was conducted all over the country in randomly selected 31 districts. The total population of 85,135 people, aged 50 years and above, and of course all statistical is taken care of adjusting on sampling, weights, age and gender adjustment, etc. And various socio-demographic data was already available with us, age-wise, gender-wise, urban, rural data. And what we found that this is the range of effective cataract surgical coverage all over the country. You got average of 36.2%. Highest was in Delhi, around 56%, and lowest was as low as 9.5% in one of the district in Odisha, that is in eastern India. And what we realize, we also assess effective cataract surgical coverage, the absolute gap in quality as well as the relative gap. And it was surprising that when you assess the cataract surgical coverage by 6 by 12 cutoff, now nearly um, a large number of districts they have cataract surgical coverage less than 50%. And the quality gap was as high as 67.3% in one of the districts. I put C in Delhi, it was 30.4%. Goa was the best, where the quality gap was just 20%. So if I need to summarize about the gaps, the cataract surgical coverage as per 6 by 12 cutoff was 57.3%. That means the coverage gap was 42.7% using this cutoff. The effective cataract surgical coverage was 36.2%, and the absolute quality gap was 21.1% between cataract surgical coverage and effective cataract surgical coverage. If I use the relative quality gap, this is 36%. We can understand there is need for quality improvement of cataract surgery in our country. And we assess for various factors. What we found that, of course, the age was important factor. In older age group, the effective coverage was lesser. Illiterate population, a significant effect, in fact, was 3 times uh, lesser coverage at illiterate among people who were 10th class pass, lesser coverage in rural population. And if we go according to the demographic areas in country, in northeastern, in eastern, and in central zones, the coverage is lesser, whereas the coverage is better in North India, South India, and West. This is important indicators. As far as gender is concerned, when we assess univariate logistic regression, it was higher among males. But when on multivariate regression, it was found that the coverage is better among females. So probably age, because the life expectancy is higher among females. That can be one factor. Otherwise, it is better among females. So if talk about our country, that we have a goal of 30 to a point 30% increase in effective cataract surgical coverage. That means our goal remain as 66.7% by the year 2030. So we can easily say India is not going to achieve universal coverage if we keep target according to the what it is being flagged by WHO and other agencies. Of course, a lot of policy implications. The first thing is that at least we have a baseline indicators, as Dr. Sumit was mentioning, because at that time in RAD survey methodology, unaided vision was not there. We could not assess effective refractive error coverage for the cat. So for cataract surgical coverage, we have baseline data, but for effective refractive error coverage, probably this coming next survey, national survey, will be able to provide effective refractive coverage. Of course, geographical variations are there, and it is important that services should be provided in areas, especially northeast India, which are difficult area actually, in eastern part of the country and also in the central part of the country. No need to say about quality. A lot of training is required beside assessing. It is quality is more important, and probably promoting education and awareness in the community. Demand generation in the community is also very important as far as cataract surgeries are concerned. So to conclude, of course, effective cataract surgical coverage is important indicators providing quality of cataract surgery as well as coverage of the cataract surgeries. Development, especially education, urbanization, and geographical locations. In fact, that should be taken as indicators for visual acuity. Visual acuity should be taken as indicator for development. That is the requirement at this stage, especially India and other part. Gender inequality, which we are thinking maybe an important component. Everyone was saying the coverage is much lesser in women. That is not there in our country. And that component is being well covered. And of course, there is need for a focus policy changes in our country. Thank you very much.
See, so, invite any comments, question? Because of course, it's a good study.
I think it's a very mammoth task, and I think the next one is much more mammoth. So one big question is like, we know that uncorrected refractory is one of the major cause of reduced effective cataract surgical. Look at other causes also, like how many was because of uncorrected refractive error not using the eye.
Yeah, but that was presented as a report that among the causes of poor quality outcome of cataract surgery. And I remember I saw the report. We showed that the refractive error is responsible for the 8% of the poor outcome of cataract surgery in our country. Just 8%.
That's less. And there are other causes with
But let me tell you, it is poor means less than 6 by 60. If we include less than 6 by 12 as the outcome of cataract, the number will be much higher, must be around 25-30%.
Because there are some 9% cover, effective coverage versus ranging from 90%. So there is a range. So properly look at what are the causes in 9%. It cannot be refractive error alone in that type. It can many other things going.
You're talking about for cataract surgical.
It's effective cataract surgical.
So there are so many factors are there. Because it's not only refractive error. In fact, cataract surgery quality, that is the key and most important factor in the country.
So for the district which showed very less effective ECSC,
Strategy should be different for different places because strategy cannot be one. So where the quality is good, probably you have to look something else. So probably you have to divide the regions also in different zones. Where surgical outcomes are, surgical techniques are bad, then you have to improve on the technique. Right. Here, refractive error is there, you have to work on strategy to improve refractive error. So all size will not, one size will not fit off. Probably you have to have different strategy for different techniques. So
Yes.
And if I could just follow to what Goet mentioned, and I think from the presentation was it very clear, it cannot have one cutoff definition where you're looking at data from the population where surgical practice has changed significantly over the years, and therefore stratifying it by age and then calculating the effective cataract surgical coverage is going to tell you whether quality has improved or not improved over the years. So people who've been operated in the 70s and 80s, their effective cataract surgical coverage because of its non-intraocular lens implant surgery is definitely going to be very bad compared to those who are operated later. So instead of having one single cutoff, it is important to also take and stratify by the age at which the surgery was done. And that data is available and you could have a look at that.
along with the 8 he get another day you can get how you are better this ideas, 5 7 years, probably stand that.
Yeah, thank you. So very good suggestion for Dr. Nitish here. You that yes, the duration of surgery as well as date when surgery was conducted, that can also give us a clear indication about cancers.
You can show a thread for some issues. Track